Okay, good evening. Welcome to all of you to our EBCP webinar this evening. My name is Alexander Warber and I will be the moderator tonight. I'm really happy that so many of you have registered for this webinar, and I think we'll just go ahead and start the program. We have a very interesting program this evening about ECMO, and we have some excellent speakers to cover the topics of ECMO and COVID. The original program that you saw that was announced on the EBCP website had to be changed a little bit due to unforeseen circumstances. And Stephen Tsui, who was announced earlier, he will give his talk at a later occasion. I would really like to thank Adrian Bauer very much for stepping in at very short notice. Adrian is a perfusionist from the Coswig Heart Center in Germany, and he is very active in the German, European, and international perfusion societies. He has a PhD from the University of Aarhus, and he is at present the president of the German Society for Cardiovascular Engineering, and he's also the vice chairman of the European Board of Cardiovascular Perfusion. So I'm very happy to have him with us tonight and to talk to us about the topic VV is not VA, the differences between the two ECMO strategies. Adrian, are you ready to start your presentation?
Yes, I am. Thank you very much for your nice introduction. And yeah, it's my pleasure to overtake that place here and to give my talk. To be honest, I have prepared that talk for a webinar last week, almost in that fashion, what I'm doing now, and that helps me to bring it to a broader auditorium, even not just to the German perfusionists. Dear my colleagues, you see some of the slides again this week, but I hope it will be interesting as well for you. And yeah, VV is not VA. The title below could also be the perfusionist or the cardiac perfusionist view on VV ECMO. And I will explain later what I mean with that. So that's just the overview what I want to do with you. We just step in what means SARS-CoV-2 ARDS for us in cardiac surgery, even in that special circumstances that you work like me in a heart center without a special clinic for lungs or for pulmonary diseases. And then I will go through the differences between VV and VA ECMO, and then I will present you how we handle that for us almost more or less new field and special aspects of VV ECMOs in a cardiac center. At the end, I will a little bit go through the studies and probably bring up the one or another point to discuss even later on then after the talk from Professor Larusso. VV ECMO at heart surgery. So what means that? We are just as cardiac centers a kind of reservoir for the healthcare system. That means when all the other clinics are full with COVID patients, then that patient comes to us. And beginning this year, that patient comes, and there was a sentence on the door to the ICU. In German is we say, now we have to sell it. I know that saying is not in English the same, but it's almost the fat is in the fire, and that was the case. The patients come to us, and they come in the early 2021, and starting here almost under the peak of the second wave, and we still have patients until the end of May. And now, of course, we have patients again on our ICU. So yeah, we are, regarding ECMO, we are the kings. We're perfusionists. We're doing ECMO even until, even before H1N1 came up, and all the ECMO therapy goes also to the pulmonary centers. We was more or less the absolutely professionals behind the technology. But what we don't have is a high experience in VV ECMO. And that was the reason why we have to change something in our thinking and something in our doing during the daily routine. And how we reach that, I will explain later. Just going through the nomenclatures of ECMO, what is ECMO is on the one hand for the heart, and we all know that we ECMO, ECLS, or nowadays also ECPR, an upcoming field. I see that more and more in the future, even because of good new technologies and good more possibilities and more experiences with ECPR. And the other hand, the treatment of the lung. You can call it ECMO, ECLA, whatever. I think VV ECMO is the best term to express what kind of therapy that is. Indications and perfusion physiology. You have an indication for VV ECMO if you have a primary heart failure with cardiogenic shock, of course. That's what we are doing every week. But for VV ECMO, the indication is a progressive hypoxemia or hypercapnia. I will come to that later on. What's the difference in perfusion physiology in the body? You all know that, but I just want to repeat it now. The ECMO is just running in the venous system. It's in parallel to the venous system. It's not bypassing any kind of organs. So that's the main difference from a VV ECMO to a VA ECMO. VA ECMO is bypassing the heart and the lung, partly or completely. So, and that's very important to understand what's happened then in the body. So there are very good guidelines published by ELSO. You know, Professor Larusso is one of the men, the big heads in the ELSO, and you probably will hear more about that later on. You have hypoxemia and you have hypercapnia as independent indication for such an ECMO. If you don't have contraindication, then you can or you should use such an ECMO system. So, of course, what are contraindications? We also want to talk about age later on. Obesity, a problem even with COVID patients. Most of you know that. And if you have a patient consider for VA ECMO, that's a relative or probably also an absolute contraindication for VV ECMO. If you have patients with high dose vasopressor requirement and pulmonary dysfunction, after bringing oxygen back into the patient, the demand of vasopressors, the need for vasopressors will go down for sure. We see that in many of our patients. So that's not a contraindication. If the heart is fine, then it's no problem if they have vasopressors before they go on the ECMO system. Cannulations for VA, you all know that. I don't want to waste too much time on that. You all know that approaches, and the topic for this evening is VV ECMO. So I want shortly go to VV ECMO. There are in principle more or less 4 ways to doing it. The most popular way is the femoral jugular approach. Means draw out the blood out of the cardia and then go give it back to the jugular vein. You can, if you want, also throw out the blood out of the jugular vein and give it back to the femoral vein. We will talk about that later on in the next topic, what I will show you. And femoral is also possible. And of course, now even for awake ECMOs, it's a very good thing to have the double cannulas. There are different types of cannulas on the market. This is just an example. And the good thing with that is, of course, you have just one catheter in that patient, and you can also mobilize the patients. That's a good approach even for awake. So, what's the difference in the, I call it perfusion physiology. If you have a venous ECMO, a venous ECMO, a VV ECMO, there is no heart assistance, of course. everybody understands it. With venial arterial ECMO, you can you support the heart, you bypass the heart, and it's more or less adjustable what you are doing. The pulmonary blood flow and the pulmonary arterial pressure will be constant in VV ECMO, but will be reduced when you have a VA ECMO. Of course, there's less blood flow, so and therefore also less pulmonary flow and pressure. The mean arterial pressure is not influenced by a VV ECMO, but adjustable with a VV arterial ECMO. Of course, together with volume and vasopressors and so on, but it's adjustable. The systolic blood pressure, the central venous blood pressure will be not influenced by a VV ECMO, but will be influenced by it will be reduced by a VA ECMO. The O2 saturation will be in the arteria pulmonalis, will be high in a VV ECMO and not influenced with a VA ECMO. The distribution of the blood is homogeneous in the VV ECMO. That's a very important point. We talked about it. No organ is bypassed. It's just running around in parallel to the venous system, but inhomogeneous depending on the cardiac index and the ECMO flow and the cannulation. So you go hardly in that perfusion physiology of the arterial system. Sometimes you have you have a backflow in the aorta and so on. I will come to that point later. So the BO2 with a VA ECMO, and most of you know that, in the best way is a little bit higher, but it's not the case that you can more or less independently adjust that O2 in the arterial system. You can raise it up, but you have to look more to the saturation. That's your target. And it's not in that way adjustable like in the VA ECMO. The CO2 is normal and optimal and adjustable with the VV system and also with the VA system. So back to the more or less indications for VV ECMO, reversible lung disease, pneumonia possible with a perhaps secondary hypoxia-induced myocardial dysfunction. I mentioned it before. It's a classical indication for VV ECMO. But there are also patients in the gray, probably viral pneumonia with coexisting myocarditis or with myocarditis with pulmonary edema. Then you came in a certain point that you also probably have a heart failure and that need then the circulatory support. I think also Professor Larusso will a little bit talk about that later on, the border between the decision to have a VV ECMO and when to change to a VA. If you use a VA ECMO, and you all know that, then you have other problems than to compared to a VV ECMO. There you can have a differential hypoxemia, means the Harlequin phenomenon with the deoxygenated blood coming from the lung and then goes to the coronary system and probably also to the cerebral arteries. You have the risk of the arterial cannulation, of course. The bleeding on the arterial side is almost worse than to a venous side. And that patients have more, and you can read that in the papers, have more complications with the vascular system. So that's the difference between the VA and the VV system. What are the special aspects now for a VV system, and what should we be aware? And we decide, because we have no experience or not that experience with VV ECMOs, and even not with COVID patients with a hard ARDS, to learn from others. And we make a lot of telephone calls. I spoke with Lean, for example. I spoke with other colleagues, and of course we looked for studies. And this study here from Paris is a very good one. And they have survivors after ECMO with more than 60%, which is very good. So we read through that paper and we looked what they are doing, and we adapted in our clinic, in our approach to use a VV ECMO in even in the COVID patients. So what are you doing if you adjust or if you set your FE2 in a VA ECMO? Yes, you control the partial PO2. But how is it in a VV ECMO? It's different. And look at that paper. They always, in all patients, use 100%, which means an FeO2 of 1.0. We adopt that in the same way and have good experiences with them. So, what's about the sweet gas flow? There's a very, very tricky thing. And believe me, you don't consider that if you don't hear it before. And even that intensivists and anesthetists learned so much since 2009 in H1N1 pandemic, epidemic situation in the world. And this one was also pretty new for me. We was not aware of that fact, because what's happened? You get patients with a high PCO2, and as perfusionists, you want to have a nice blood gas analyzed with a nice PCO2, probably in the upper range, 45 millimeter Hg, but it must be nice. So therefore, you start with the sweep gas flow by 8 liters, 10 liters. And then you decrease the PCO2 strongly rapid. And what's happened then is that you can provoke, and this paper's explained it very trustful, neurological complications and intracranial bleeding. Could be. This is not so good explained, but neurological complications are very good explained. And if you look here, the CO2 decrease is here more than 50 per day, then they have the most neurological complications. The reason is that you have a more or less spasmus, and you know the CO2 makes your vessels open. All of you use that when you are go to pH strategy by deep hypothermia cardiac arrest. Then you want to open the vessels in the brain to cool the cerebrum in a good way. And the other way around is the problem in that patient. If they come with a high PCO2 and you decrease it too rapid, then you can get that problems. And that's not new, but here in 2014, publication was out regarding that problem. And yeah, you have to consider that. And it was very interesting for me also to see that in our webinar last week, presented by Professor Hoyer. And yeah, what can you do? Decrease slowly. For example, not more than 1.5 millimeter Hg per hour. And you can do that with your gas flow, of course. And control with NIRS. Then you will see whether there is a spasmus or not, and you can go against it and probably a little bit reduce your speed in reducing the CO2 in the patient. So very important. What's about the blood flow? In VA ECMO, it's obviously what we are doing every day. We're raising up the mean arterial pressure. What about in the VV ECMO? In the VV ECMO, you control the arterial O2 saturation. And believe me, it works. It's not the case. We are still in 1.0 FeO2 on the speed gas flow controller, but to bring more oxygen blood into the patient means the saturation will raise up at the arterial side. The Paris paper explained it in the same way, and here you can read it again. By the way, I will circle around all the papers as a reference list through the chat later on, so you can then read the paper by yourself. There's also the next problem is the recirculation phenomena. Recirculation phenomena means that you suck your blood into the venous system, what you are giving before over the arterial cannula, the cannula giving the blood back to the patients. And in that setup, femoral jugular, it is there, but not in that big, not as that big problem. The problem is then when that cannula is too close to that cannula. It is more, it occurs more in the jugular femoral setup. We never do that, but some colleagues are doing that, so be aware of that. And in the femoral setup, you have also recirculation phenomena, and you have to be aware of that. And it's easy to find out to find that problem. If you are under suspicion that that happened, you just have to make analysis of out of the venous line, and then you will see how high the saturation is there. And if the saturation too high, you can throw back that cannula a little bit, and then that problem will disappear in the most of the cases. So this is also a wonderful paper, I think, and we discussed it a lot also with Lean here and also with the colleague from US. And I think it's very good to handle that problem with the exchange education, but also to understand how to bring O2 into the patient, because you can calculate the performance of your oxygenator, and you can calculate it with the with the O2 transfer calculation. That means you take the content of the arterial blood minus the content of the venous blood, multiply by 10 and the blood flow, and then you will get the O2 transfer rate. And then you have more or less a feeling how good your membrane lung is functioning. So we are doing that in our clinic. Even then, if we have the suspicion that there's something wrong with the oxygenator, we have a calculation, an Excel file, then we put in the hemoglobin and the flow and the saturations and so on. And then this file will calculate you whether you're in a good manner or whether you have a good transport or not. And if you see it here, the influence of hemoglobin and hematocrit on that patient, that's very important. You need that carriers, you need blood in that patient, and it makes not sense to have that too less. You need a high hemoglobin, and then you will also have a good transfer rate. We use that to calculate the transfer rate, but also to look how much blood saturation O2 blood we bring into the patient. There's also that overview here. I think it's very fine. I don't step in the hematological profile. Just for you, you need good guys with a good understanding of anticoagulation processes. And then you don't have that big problems here on the other side. You have to monitor the pressure. Of course, delta P is not new for us as perfusionists. I don't want to go on that, but here that's interesting. They call it the oxygenator membrane lung. Okay, it's nice. It's the oxygenator, but here that's important, and that's according to what are we doing here. Here you can see how is the O2 transfer, and is that in a lower if you have lower values here, then you can estimate probably an oxygenator change out before it happens. So it's very important to do that in a good circumstances and not in an emergency situation. The same is with the CO2. It's much more easier to calculate just before minus after, and you will see what's happened with the CO2 transfer rate. So, but yeah, that's what we are doing. Indication for change are to watch over the system, look for the oxygen transfer, FaO2 of 1.0, optimal hemoglobin, and looking after the carbon dioxide elimination and of look after clotting, of course. Routine controls are delta P, if possible, permanent. If not possible, you have to measure it in a certain way. Calculation parameters. You also know, and the Euro also is also recommended to have higher values, even in the COVID patients, because of the hypercoagulated state of that patients. You have to monitor possible venous shunts, I talked about before, and you have to take blood samples. You don't have to make that DO2 or VO2 calculation every day. What you should do is every day blood gas analyzed from the arterial blood after the oxygenator. And if that over 200, everything is fine, it's following it down, goes below 200, then you have a change of indication. So that's what we are doing in our clinic. Sorry, it's in German, but I will expand it a little bit. You came to the patient and he is hypoxic on the ECMO system, of course. Then you make the post-oxygenator blood gas analysis and look, is it below 200? And is the transfer rate low? And probably you see a D-dimer raising or other signs of a more or less clotting oxy. Then you have an oxygenator change out indication. And before the question comes up, we do it always. We change always the whole system, not just the oxygenator, because if you have problems in the oxygenator, you can expect it as well in the pump and probably in the lungs. If that's not the case, then you have to look after a shunt. Probably you have to reposition the cannulas, and you have always to optimize the DO2. So give blood, look that you have enough flow for that patient. It makes no sense, a 100 kilo man with 3 liters. You need a certain flow on that patients, and then it will going good. Weaning from ECMO system, we do what we don't. Okay, we say the patient is better, the X-ray is better, and we are just before weaning the system. What we are doing is reduce the flow at least up down to 3, probably 2 liters. Why? Here, this a very interesting paper you see even in that centrifugal pumps. As lower the rate is, the rotations per minute, as more shear stress will appear. That means you think probably more flow is more shear stress, but that's not true for centrifugal pumps. Very interesting paper here. And the next thing is, if you go too much down with the flow, you have probably problems with the anticoagulation, even in the COVID patient. So then we are on 3 liters. The CO2 is below 45. Then we reduce the gas flow down to 0. Wait, if the patient is good, then we expand the system. That's the way it works. It's not our idea. It comes from that paper. Okay. ECMO and SARS-CoV-2. Just a short look to literature. There is pretty new out and published a meta-analysis overwatching 1,896 patients. Okay, sounds good, sounds interesting. If looking in that meta-analysis, you will find the biggest study here is the Euro also registry study. And then came the Paris study I mentioned before. And this study from Takeda. I do my best to find that study. I find a letter to a tutor and something else, but not the study. Probably one of the colleagues here in the auditorium have that study, please send it to me. But just to give you an overview how that meta-analysis works. And the rest are small groups. So, one interesting thing, I put the age in. You see Here, that's the mortality rate, that you have more mortality in the older groups. And you see on the other hand, you have a better mortality in the groups with younger patients. So that's the first finding in what is obviously in that meta-analysis. Do we have prospective randomized studies on ECMO? Yes, we do. That's one example for it. But in non-COVID patients, it's published in 2018, but it's really ECMO and very interesting. They have mortality rates about 37% and 47% without ECMO, with ECMO better than without ECMO. What they have done is they have made an intention to treat, which means we have a crossover, and that crossover was a high crossover, I think. 35 patients. The physician decide, no, this patient's getting ECMO. And then, in intention to treat, this 35 patients will be calculated as non-ECMO patients. Consider that. I have done a little bit a recalculation and calculate the per protocol mortality. Per protocol mortality is much more better for the ECMO. The survivors are around 60% and 35 for the patients without ECMO. Survivors. Okay. So you will hear more later on in the next talk, and I'm absolutely looking forward to it. They have also survivors over 62 with 62% in that study, but also again look to the age 49 years in the cohort with in the full cohort. The 90-day mortality in Paris, the study mentioned before, was 36%, which is very good. That means they have a lot of survivors in that studies, 64. And yeah, now we can say, oh, it's not that bad. It could be better, of course, 100%, but it's almost good. But sorry, I have to put a little bit water in that wine, because our feelings, and when I talked with colleagues, was different to that results. And if you look just as an example to that nice study published last month, you see COVID patients and patients with influenza, both on ECMO, and they have surviving rate of 35 and 43%. It's lower than what we see before in the other studies. And I think this is a good study, even to compare both influenza and COVID. You see, COVID has less survivors than the influenza group, but it's lower than in the meta-analysis, and it's lower like in the Europeans. And then is one interesting published from Professor Kianidis. He is a very famous intensivist in Germany, and I think also in other societies. And I know he's also part of a lot of committees. And what he has done is very, very interesting. He just made a sample out of the whole population. He asked our biggest health insurance company and looked for all the patients with COVID on ECMO, and then look what's happened with that patient. And what he finds is interesting. The survivors was 27%. So, and I can't believe that's a typical German problem. There are a lot of things what can explain that finding, but it's not, I can't believe that's a typical German problem. If you look to the patients, then you will find in his analysis that they are older than Euro-ELSO and in the Paris trial. They are they have more comorbidity. 60% for dialysis, for example, compared to 43 and 44 in the EURO-ELSO in the Paris trial. And they have prolonged median time from the onset of ventilation, intubation, until the ECMO was started. And yes, of course, you see that here, the older patient dies more. And if you have, if you are short in your decision in the patient, then you will have better survival rates. That's also true. So probably in the age, we are a little bit too liberal, and in make the decision, we must be more liberal. That could be one way to explain it. And that's the same what we also have seen in our patients. 25% are dying from the old patients. And of course, if one more survived, then we are over 30%, but that's not what we expect. But look at our age. In the middle, 65. The two youngest was 62, and that both survived it. Yeah, conclusion. Don't forget the lung. In our webinar last week, Professor Hoyer explained everything about ultra protective ventilation. That's very important thing. It's not enough to put the patient on the ECMO. It's nice, and everything is fine, but you have to treat the lung, and you have to look after the lung, and have to do everything. Driving pressure, prone position, of course, consider awake ECMO, and so on and so on. That would be an extra topic for a talk, I think. So in conclusion, the survival rates and registries have very good survival rate. Unfortunately, we in Germany not. Probably we have to set something new, have to rethink a little bit. I think also every clinic contributing to a registry like EURO-ELSO or contributing to a study is very motivated to doing it. And that's not the case for all the clinics are doing COVID ECMOs. And special ECMOs, special aspects on ECMO, just to take it home probably for you. FiO2, always 1.0. Increase the gas flow slowly, start with 1 liter and then go slowly up. Keep the hematocrit in a good manner, in a good way. You control with your blood flow, not the mean arterial pressure, you control the PO2. Think about hemolysis. Don't go below 2 liters with your ECMO system. And use transfer rates as early warning parameter, and look after the recirculation phenomena. That's from my side. I will circulate that list here with the references to you if you want. Otherwise, you can write me.
Yes, thank you very much, Adrian. That was an excellent overview over the whole topic of VV and VA ECMO. And there were some questions coming in, but I think in the interest of time, we'll continue with the second presentation, and then we'll have a look at some of the questions. Now, thank you, Adrian. It's a great pleasure to introduce our next speaker, Roberto Larusso. I think he doesn't really need an introduction. He's very well known in the field of cardiac surgery and ECMO, and he's a cardiac surgeon and professor at the University of Maastricht in the Netherlands, and he's done a lot of work within ELSO, EURO-ELSO, and he has also been the chairman of the recently published guidelines for or expert consensus on post-cardiotomy extracorporeal life support in adult patients. Dear Roberto, please give us some new insights into the lessons that you have learned from conducting the EURO-ECMO COVID study. Please.
Thank you, Alexander. Thank you, Jerdy, also for the invitation, and really appreciate it. And I see a lot of connections, so a lot of friends around the world. And I will start with my presentation, which is a little bit of information regarding the Euro-ELSO and ELSO COVID studies that has been done so far, because they are still ongoing, and I will explain you a little bit more. These are my disclosures. I'm using this drawing from Julia, who's a 9-year-old girl who presented this during a PhD I was involved in, and it was, of course, about COVID, as you can imagine, and the patient in the ICU. I really love this drawing, and I'm using this to start introducing a couple of topics. First of all, I like the drawing because the patient was on ECMO but smiling, so hoping that this is a little bit wishful thinking. And then the virus here also close within the heart, and I will explain you why. So just to start with, I want to highlight why we did the studies that you have been also listening up to now with from Adrian about Euro-ELSO and ELSO. Because at the very beginning of the pandemic, this was a letter to the editor published in February. This was really importantly highlighting that there was a word of caution and skepticism about the use of ECMO in COVID-19 patients. And actually, it was even in this letter suggested to skip it, to avoid the use of ECMO. And this was, of course, based on the very few data coming from China. You can see here that the survival, in-hospital survival was really poor. Then I was in Italy at the middle of February 2020, and I had a lot of colleagues calling me and saying, well, what should we do? Because we are not thinking to apply ECMO in COVID-19 patients who are coming every day in hundreds. We are really think that doing something which is not efficient, not effective. So why should we do? So we, in Maastricht, with my research group, we had the idea that maybe this kind of information were really a sort of misinformation, so disinformation, and we wanted to do something providing really an up-to-date and continuous information regarding the use of ECMO in COVID-19. And that's the reason why the idea, let's say, was born at the end of February 2020. We started making immediately a data set, very basic data set, because we didn't want to ask too many data to all the centers. And we started with some centers in March 15, 2020. And we decided to provide a weekly report to all the people through the Euro-ELSO website in order to have updated information about the use of ECMO, how many, in which centers, and of course, if the patients were surviving or dying or whatever. So that was the basic, let's say, move, the basic insight in our experience. And here I wrote October, but of course now the last report is just a couple of days ago, so December 13. This was, as I said, December 13. So we, from March 2020, we provided every week a report about the use of ECMO in Europe, also Eastern Europe, Israel. So this is really been a lot of work. I can tell you, my research group must be really recommended for the passion and the extra time dedicated to this project. And you can see here that we started with 51 centers in March 2020, and now we have more than 200 centers throughout Europe, Israel, and Russia. So I think that was really a tremendous effort from all the participants, which I really, I'm so grateful to all of them. And they gave us the opportunity to provide some data, again, every week to the users, to the people, also to the patients. Just to give you an idea what was going on during the 4 waves so far. So this is the first wave. You can see we reached 1,531 patients. The second wave, almost 3,500, you can see, and you can clearly see from September 2020 to March 21. Then the third wave, you can see again here, we have more than 5,000 patients. And the fourth wave, unfortunately, and this is the problem that we are facing, particularly in the Netherlands, that the situation now is really critical again. And we have now up to December 13, more than 5,500 patients. So still counting, unfortunately. But what about the situation based on this data? We published the first letter because we wanted to finish and completed the data analysis and collection, and it is now ongoing. Why? Because we didn't want only to provide the in-hospital survival or complications. Now we are evaluating the 6-month follow-up of each wave. So now we are submitting the paper regarding the first wave plus 6-month follow-up. So I cannot provide you the very last data of the follow-up, but I tell you they are very, very interesting. So I can give you preliminary data about in-hospital outcome. And you can see here. So this is the first wave. And in the first wave, we had on ECMO mortality of 39.2%. I just urge you to have really attention on these numbers. So 39.2 on ECMO, the mortality on ECMO. And after ECMO weaning, so successful ECMO weaning, still 4.6% of patients died in hospital. So again, look at this data. If you make the sum, you have a little bit higher, let's say around 44% of in-hospital mortality. During the second wave, instead, we had a little bit of increase in mortality on ECMO, whereas we had a small decrease in mortality after ECMO weaning. The third wave, the same thing. Again, a small increase in hospital mortality on ECMO and a small decrease after ECMO weaning, still in hospital. And finally, again, the same rate, 41.9 and 3.0. So looking at the fourth wave, we could see that unfortunately, the mortality on ECMO slightly increased, whereas the mortality after ECMO weaning, still on hospital, slightly decreased. And this is very important, and I will come back to this information. Another information which is, I think, known by everybody of us is the mean age was really a young patient, so less than 52 years, and the age range between 16 and 82. Another very important information, because we all thought that let's say the candidate or the patient enrolled for ECMO were all youngers, but that was not the case. In many centers, patients older than 70 years were submitted to ECMO. And you can see already known that COVID was much, much more prevalent in the male gender. This was already shown by Adrian. This was the paper published in Lancet 1 year ago, but this was from the ELSO organization, so the worldwide, not EuroELSO organization. And you can see here that very importantly, that the patient, the in-hospital death was only 37%. So again, a little bit less than what we saw, but this was only for the first wave. Another important thing that we saw is the high rate of cerebral bleeding. This was another very interesting aspect, unfortunately, that we could see also in the EuroELSO experience. And this is, of course, the cumulative incidence of mortality. And what is also important here to see how much how many patients were still hospitalized after the discharge from the intensive care unit, and also submitted to rehabilitation departures or facilities. Another very important things from other important things from the ELSO registry paper were the predictors. As you can see, of course, the older age, the presence of immunocompromised situation, the presence of chronic respiratory disease, the presence of ECMO arrest, cardiac arrest before ECMO start, and finally, the incidence of acute kidney injury and the use of veno-arterial or veno-veno arterial, veno-arterial VAV mode were also predictors of unfavorable outcome. We published another research letter on Lancet Respiratory Medicine in again in March 2021. Why? Because we saw, as I showed you from the difference from the first and second wave, that the in-hospital mortality was increasing, and indeed that was the case. So what we saw is that second wave was much worse than the first wave, despite the increasing experience and increasing knowledge about how to treat these patients. And why? Why was so? I can show you a second paper of the ELSO registry, again, worldwide experience, that was published in September, a few months ago in Lancet. And what did we do? So we compared from the ELSO registry the first wave with the second wave of the same centers. But after all, we also look at the centers starting in the second wave. So we compare the first wave with the second wave based on the same centers starting in the first wave, or beginners starting ECMO in the second wave. And that was really interesting because we had a lot of patients to compare and to analyze. And also we saw a difference from the first and second wave. And I show you this because it's important. This showed clearly that the patient in the second wave were much worse. And I show you here, look at the amount of corticosteroids or steroids used in the first wave. This is the left column. And then in the second wave in the same center. So you can see almost 92% as compared to 77%. And look also at the beginners, so the center starting ECMO in the second wave. Also high, but not as high as the, let's say, more experienced centers. But this means that patients arrived on at the admittance already treated with steroids, already treated with proning, etc., etc. So the second wave had patients in whom the conventional therapy was used much longer and they were not effective. And indeed, you can see here, this is the mortality. You can see group 1, the blue lines, the mortality was much less than the same centers in the wave, the second wave. So this means that the same centers, despite the experience gained in the first wave, they were having worse results. But look also at the centers, the green line, starting using ECMO in the second wave, even higher mortality. And this is very important. Just to show, this is the mortality, so the blue part. So in the first wave at the left side, and then the same centers in the second wave, and the center starting ECMO in the second wave here. So even higher mortality. But also the type of patient who were discharged from the ICU, much more patients were still requiring admittance in rehabilitation or in other hospitals, just to continue the treatment of respiratory compromise. So again, these patients were certainly worse than the first wave. What about something which, in my point of view, has been really important, the heart and COVID? So I think that this is a question we have to pose ourselves. So did we forget the heart? Sorry, not the heat, the heart. And this was the first publication in April 2020, as you can see here, about the presence of the virus. You can see clearly the coronavirus in the myocardium, in the myocardial biopsy. But what kind of myocardial injury is present in COVID-19? A lot. But the most important ones are, of course, sepsis, are disseminated intravascular coagulation, so thrombi, and particularly in the pulmonary vasculature, pulmonary hypertension, and you can see right ventricular dilatation and ventricular thrombosis. So what is the prevalence and impact of myocardial injury? You can see here, this is a publication by Lala and colleagues. They look about the amount and the prevalence of myocardial injury. So you can see 36%. And the more was severe the involvement, and the higher was the in-hospital mortality, as you can see here, the mortality was higher than 50% in the admitted patients. But again, the type of myocardial injury, we could define two types: acute myocardial injury and patient with already chronic cardiovascular disease. In this study, they found that more than 31% of the COVID patients admitted in the hospital had signs of myocardial injury. But what was really important is almost 80% of these patients had signs of new myocardial injury, whereas the other had chronic. And you can see again, the cumulative incidence of mortality, what's the difference between patients having cardiovascular also diseases with, as compared to patients with COVID, but no cardiovascular diseases. And you can see that the chronic and acute myocardial injury, they were correlated and associated with a very high in-hospital mortality. But what about the signs and types? This was a study, published by Putman and colleagues, looking at 100 patients with magnetic resonance imaging. And very interesting, they found almost 80% of these patients showed a cardiac involvement, and 60% showed signs of myocardial inflammation, so myocarditis. And what about the use of echo? So that was MRI, but the echo gave a lot of good information. And look, the presence of left and right ventricular abnormalities by echo was present in more than a third of the patient. And very importantly, the echo management could change the patient treatment and therapy in more than a third of the COVID-19 patients. But what about the use of echo to evaluate what kind of injury the patient in COVID had? And what was very important is that this study by Lasser and colleagues, they showed that both right and left ventricle were significantly impaired, but particularly the right ventricle was involved, and these signs were absolutely independently associated with a COVID-related death. So this patient with the right ventricular involvement had a much higher rate of in-hospital mortality. But this is also very important, how prevalent was. And this study by Corica and colleagues found that 1 out of 5 patients had signs of right ventricular dysfunction. And this was again associated with a high mortality in the hospital. So should we have used or should we use more mechanical support? Again, from the EuroELSO study, unfortunately, we saw that the use of cardiocirculatory support, so cardiorespiratory support, was present almost in 10% in the first wave, but then less than 8% in the second wave, 8% in the third wave, and less than 8% again in the fourth wave. So the use of cardiorespiratory support associated has been really, really limited in the COVID-19 treatment, at least in Europe, but was also in the ELSO registry. So in the worldwide, you can see only 3% of the patient had a concomitant cardiac and cardiorespiratory support. But we made this is a submitted for publication. We made a review of the literature, and you can see we had more than 2,500 patients. And again, only 6.3% of the COVID-19 on ECMO had also a cardiocirculatory support. So really, really limited. But Mustafa and colleagues from Chicago, they showed a fantastic, I would say, impressive initial series of 40 patients. They used the Protect Duo cannula, which allows you to have a VV ECMO and right ventricular support, and look at the amount of in-hospital survival, 73%, which is also went higher because the 5 patients still hospitalized at the moment of publication at the end were all survivors. So the survival reached almost 80% on these 40 patients. Then they showed an update of this experience recently with 80 patients treated with a Protect Duo, and they matched these 80 patients with a non-ECMO patient, but still ventilated, so mechanical ventilated. And I think the results are impressive. Look at the amount of inotropy requirement in the ECMO patient with a right ventricular support, 1.3% versus 36.3%. Of course, there was more bleeding because of the cannula, but look also the septic shock, much lower as compared to patients not submitted to ECMO. And also look at the amount of complication like acute renal injury or liver injury, much lower, significantly lower in the patients submitted to this kind of ECMO, so right ventricular support plus VV ECMO as compared to mechanical ventilated patients. And the mortality, of course, was much higher and in the mechanical ventilating only, and the in-hospital survival was 75%, as you can see, impressive difference. And Kain and colleagues used the same configuration, so the Protect Duo cannula, but look at the data. So the procedure duration only 16 minutes, duration of support 13 days, no device complication or malposition or dislodgement, and also look at the survival to device explant, almost 85%. And again, look at the result between the RVAD ECMO again versus mechanical ventilation alone is impressive. I think this is really something that we should look at. And look at the acute kidney injury in this experience, 0% in the patients submitted to combined right ventricular support and VV ECMO as compared to more than 70% in the mechanical ventilation group. And again, striking difference in the in-hospital mortality. So we wrote this editorial recently stating that maybe veno arterial ECMO has been underutilized. I would say that the concomitant VV ECMO and right ventricular support most likely has been underutilized. So in conclusion, I think that we can say that the COVID pandemic is still an extraordinary challenge for the ECMO community worldwide. We are still struggling, we are still collecting data, and we are still learning, unfortunately. But what we know is the first wave, paradoxically, was the best one in terms of results, most likely because we treated patients much earlier and not submitted to prolonged non-invasive ventilation, steroids, and so forth. The second way, therefore, the patient had more complex situation, longer ECMO, and also more hospitalization after discharge. We found some factors like age, renal failure, and so forth. But what we found also is the lack of concomitant cardiovascular support, which was present or is present in more than a fourth of the patients. And I think that we performed that in less than 10% of the patients. So certainly much lower than we think needed. We are now analyzing the follow-up at 6 months or longer, and we hope to give you more data shortly. Thank you very much for your kind invitation and attention.
Thank you very much, Roberto. This was a very interesting overview over the topic of ECMO in COVID patients, and your results were very interesting. I just thought maybe I can ask you a question about the myocardial dysfunction in COVID patients. The topic of myocardial dysfunction is probably also relevant in all patients that have ARDS and that undergo ECMO treatment. Do you think that maybe this combination of VV, ECMO plus right ventricular support should be looked at for any type of lung failure?
That is a fantastic question. I tell you why, because we are exactly doing experiments now comparing this kind of, let's say, VV ECMO, which is called oxy-RVAD. So you have a VV ECMO plus right ventricular support compared to normal DV ECMO, either with double lumen or single lumen cannulas. We are now starting this experience in animal models of RDS. We have this impression. We think that in the future, most likely the combination of right ventricular support plus VV ECMO will be the most effective way, because you anticipate right ventricular dysfunction, which is present from 10 to 20% at least of the patient with severe RDS and with VV ECMO. So certainly, in my point of view, is going to be one of the major breakthrough in the future in ECMO, VV ECMO.
That's really fascinating. But do you think that the problem with myocardial dysfunction is higher in COVID patients from your clinical experience?
The issue, and then it's another very important point, is how the VV patients are monitored. We are now submitting a paper, it's an expert consensus with a lot of experts around the world, how to monitor hemodynamically speaking, the VV ECMO patient. Because we think that the patient submitted to VV ECMO are really not adequately monitored regarding the hemodynamic consequences. And we think that the right ventricle, or let's say the cardiac lung interplay, is not sufficiently monitored and adequately monitored during, particularly in severe RDS. So we think that this should be improved absolutely.
Thank you. Maybe we take one question from the questions that came in from our viewers. And Mark is asking, since the beginning of the pandemic, is triaging patients for ECMO now done at an earlier stage, such as upon admission to the ICU in your centers? What is your opinion? Are you more aggressive in most centers in Europe?
No, unfortunately not, because again, the issue now is still the problem of bed availability, personnel availability, and so forth. But what we know is, we think that, first of all, patients should be really put on ECMO as early as possible. Secondly, they should be awaked. These patients should be awaked. This is another very important, if possible, of course, if they can stand, because they can cooperate, they can be compliant with the physiotherapy, and also the mechanical ventilation could be avoided most likely. So because we know that the ventilator lung injury is a major problem, even with the protective ventilation protocol.
Very good. Now, I'm really happy to tell you that up to 370 perfusionists have switched on and have listened to your talk and to Adrian's talk, and that's really, really fantastic. I think we are ready to conclude this session, this webinar, and I think we can say that we'll try to answer some of the questions that haven't been answered now later on in the chat. But thank you very much, both of you, and thank you very much for our viewers to take part in this excellent webinar. Thank you.
Thank you for the
Bye.
conversation. Thank you again.
Thank you. Have a nice evening.
Bye.